Okay, the next question is question number 121 and 122. Both have the same answer, so I will be discussing both in the same go. Question number 121. Answer is C. Question number 122. Answer is A. This is regarding Wegener's granulomatosis. Remember, it has a triad where you have upper and lower respiratory tract involvement, you have vasculitis, which is a small and medium vessels, and you have renal involvement in the form of crescentic glomerulonephritis. So, this is a classical triad of Wegener's granulomatosis, where you have upper and lower respiratory tract involvement, vasculitis, renal, crescentic glomerulonephritis. Next question is question number 123. The answer is B. Remember, regional pain syndrome, they are of two types, type 1, type 2. Type 2 occurs after trivial trauma, trivial tissue trauma. Type 2 occurs after nerve or major nerve trunk injuries, major nerve trunk injuries. Remember two phenomena with type 1, allodynia and hyperpathia. Allodynia is that there is no painful stimulus, even a pleasant stimulus is perceived as painful, whereas hyperpathia, a mild painful stimulus is perceived as a major painful stimulus. So, remember these two phenomena in patients having type 1 RPS. Next question is question number 124. Answer is A. This question is regarding cardiac tamponade and its association with jugular venous pulse. See, if you can identify jugular venous pulse in the form of a diagram, you will be able to solve most of the questions of jugular venous pulse. So, remember this diagram. This is A, C, A. See, this is A wave, C wave, X descent, V wave, Y descent. This part is atrial systole, this part is atrial diastole. Between C wave and V wave is ventricular systole. Just remember this diagram. Try to remember the basic cardiophysiology. Whenever there is a question regarding jugular venous pulse, draw this diagram and you will be able to solve all the questions of jugular venous pulse. Remember, atrial systole, atrial diastole, and this ventricular systole. Question number 125. The answer is B. Mitral stenosis will never have third heart sound. Reason: the third heart sound occurs into rapid filling phase of ventricles during early and mid diastole. And whenever you have a fixed valvular defect, the valvular defect is fixed, the area is fixed, the valves are not moving properly, so this early rapid filling phase of ventricles is impaired. So therefore you can never have S3 in mitral stenosis. Question number 126. Answer is C. The question is that which of the following heart sounds occur shortly after S2? It is all obviously ejection click. Ejection click is a systolic heart sound, early systolic heart sound. Question number 127. It says that left atrial filling pressures closely approximates. Answer is A. Left atrial pressure, it closely approximates pulmonary capillary wedge pressure. In all patients who have cardiogenic pulmonary edema, pulmonary capillary wedge pressure increases, thereby it reflects in left atrial pressure. In non-cardiogenic pulmonary edema, pulmonary capillary wedge pressure is normal, and therefore left atrial pressures are also normal. Question number 128. Again, similar to the question number 127, that patient has bilateral basal crepitations, respiratory distress, but the alveolar wedge pressure is normal. So it is a non-cardiogenic pulmonary edema. So answer is A, that is narcotic overdose, because all other choices will be having increased pulmonary capillary wedge pressures. Question number 129. Dopaminergic dose of dopamine. See, answer is A. Remember, when you give dopamine in low, medium and high dose, first is dopaminergic action, then beta agonist, and then alpha actions. This is 1 to 2 microgram per kg per minute, 2 to 5 microgram per kg per minute. Anything more than 5 microgram per kg per minute is alpha. This increases the renal blood flow, this increases the heart rate, and this increases the peripheral vascular resistance. So technically, medically speaking, the most effective therapeutic dose is 1 to 2 microgram per kg per minute. Next is question number 130. This is regarding the drugs which are used in the treatment of heart failure. The drug is Arjuna terminalis. The answer is self-explanatory. Answer is B. Arjuna terminalis used in the treatment of heart failure. Question number 131. This is again regarding a drug which is used in treatment of heart failure, a BNP analog. It is nesiritide. It is nesiritide. Remember, there are many new drugs which are available for treatment of heart failure. It is not only nitrates and vasodilators and diuretics. There are n number of drugs which are into the market and into our books. So, try to remember, this is a very important question. Question number 132. How is angina pectoris diagnosed? Answer is history. So, it is A. You do not have any test for angina pectoris. It is a classical history given by the patient of retrosternal chest pain radiating to arm, which is on exertion and is relieved by rest. So, this history itself is sufficient for diagnosis of angina pectoris. You do not need any tests. All right. Then question number 133. This is regarding Agatston score. Remember, Agatston score is for quantification of calcified plaque in coronary. It is done by CT coronary calcium scoring system. All right. So, answer is C. Agatston score for quantification of calcified plaque. Question number 134. Which test is performed to detect stunned or reversible myocardial ischemia? This is, the answer is PET scan. Remember something about stunned myocardium. Stunned myocardium. A previously normal myocardium will have a decreased ejection fraction as well as regional wall motion abnormality. However, it is reversible. So, the insult is not complete. Usually, stunned myocardium occurs in patients having septic process. The myocardium is stunned and it recovers with the conventional supportive therapy, but it does denote that there is some sort of underlying coronary artery disease which is causing some sort of reversible ischemic changes in the myocardium, and because of the septic insult you have this stunned myocardium. Next is question number 135. This is regarding TIMI score. Answer is A. TIMI score is very important. We have to learn it by heart. 0, 1, 2, 3. Okay. 0, 1, 2, 3. There are 4 stages. 0 means complete occlusion. This means partial occlusion, and there is some flow of the contrast through that occlusion. However, the flow is not sufficient. 2 is that the flow is the contrast material penetrates adequately, however, flow is really abnormal, it is not up to the mark. And 3 is complete revascularization, so that the contrast flows freely across the stricture or across the plaque. Question number 136. Which is the drug used to coat the stents? There are 2 drugs, paclitaxel and sirolimus. No need to explain this question. Answer is C. Next question is, bradycardia is a feature of obviously inferior wall MI. 137. The answer is A. Bradycardia, sometimes hypotension to inferior wall MI, decrease pulse rate, hypotension, and some ECG changes. We should remember that ST elevation in the 2, 3 AVF, right, is a hallmark of inferior wall MI. Question number 138. This is regarding the culprit vascular lesion and the site of infarct. So, remember, most culprit descending artery is left anterior descending artery, and most probable site of infarct is A, anterolateral. The answer is A. Remember this diagram. This is LAD, left anterior descending. This is left marginal. This is left circumflex. All right. This is right marginal, this is right coronary, this is left main stem, and this is a branch which goes posteriorly, posterior communicating artery. So, this is the most important culprit artery, left anterior descending, and this is the left ventricle here. So, this is the artery which is the most culprit, and it causes most of the infarcts in the anteroseptal region. Lateral wall will be caused by left marginal, lateroposterior wall will be left circumflex, right ventricular wall will be right marginal, right posterior will be PCA. Question number 139. Answer is A. See, anyone who comes to the emergency with epigastric pain, difficulty in breathing, the investigation of choice is ECG. It's for all medico legal purpose, remember that. So, there is no deviation from this concept. Similarly, question number 140. 140. 140. The answer is C, coronary angiography. See, the chest pain is for 2 hours duration, so the patient is in the window period, that is 3 hours. So we need to follow the protocol that he should be wheeled to cath lab and an immediate coronary angiography needs to be done. All right. Question number 141. This is regarding a smoker with acute epigastric discomfort for 1 hour, ECG showing ST elevation in inferior leads. So it's an inferior wall MI. The question is, what's the immediate intervention? All right. See, whenever you have a person who is within the window period, you don't thrombolize, you directly go for coronary intervention, PCI, CAG plus minus PCI. So we give aspirin in this patient. Answer is A, right, not thrombolytic therapy. Question number 142. This is regarding a complication, a dreaded complication which occurs after extensive interval MI, which is myocardial rupture leading to lethal pericardial tamponade. So answer is D, external cardiac rupture. Very difficult to manage. Patient suddenly deteriorates and may land up into refractory cardiogenic shock. Question number 143. Tendon xanthoma is most likely seen in which type of primarily hyperlipidemia? It is type 2A. So answer is A. Remember, type 1 and type 5 familial hyperlipoproteinemia or hypercholesterolemia, pancreatitis risk is maximum, and CAD risk is minimum. So pancreatitis risk is maximum, risk of coronary artery disease is minimum. Question number 144. This is regarding hypertrophic obstructive cardiomyopathy. The murmur is a harsh, loud, systolic murmur. So it radiates to neck, it radiates to back. So the answer is A, crescendo decrescendo systolic murmur, which is not a feature of HOCM. So answer is A. Similarly, question number 145, again for HOCM. Remember something about HOCM, that HOCM murmur increases by Valsalva, standing amyl nitrate, inhalation decreased by hand grip. Right, HOCM murmur increases by Valsalva, standing and amyl nitrate, and it decreases by hand grip. So the answer for question number 145 is B. Answer is B. Question number 146. So this patient has mastectomy and she was treated by doxorubicin, which is a cardiotoxic drug, and the patient is presenting to congestive heart failure. So obvious answer is B, drug induced cardiac toxicity. Remember, many anti-cancer drugs have potential cardiotoxicity. One of them is doxorubicin. Question number 147. Blunt trauma chest. Blunt trauma chest leading to acute hypotension. So diagnosis is obvious, cardiac tamponade. Answer is C, cardiac tamponade. Question number 148. Critical ischemia for peripheral artery disease, that is ankle brachial pressure index. Question number 148. See, normal ABPM is 0.9, less than 0.9. So anything which is less than 0.9 is abnormal, and anything less than 0.3 is critical. So the answer for question number 148 is C. Question number 149. True about pseudo hypertension. Very simple question. It is obviously seen in elderly because of the arteries which are stiff. Arteries which are stiff because of the calcium deposition. So the compliance becomes poorer and there is increase in the systolic BP. Right. So the answer is D. Question number 150. Main action of ivabradine. Ivabradine, remember, is a drug used in treatment of stable angina. Ivabradine used in stable angina patients with tachycardia. So the main action is bradycardia, thereby reducing the oxygen consumption demand and thereby reducing the incidence of stable angina. So answer is B. Question number 151. Mitra clip is used in the treatment of which condition? Very simple. Answer is B. Question number 152. Gallawerdin sign. It's a very important sign, Gallawerdin sign. It's a sign seen in aortic stenosis. So answer is A. What is Gallawerdin sign? Basically, that the murmur which is originating here, it is transmitted to the apex. So the systolic murmur at aortic area is transmitted to the apex and it is confused with a murmur of mitral valve. So this is Gallawerdin phenomena. Question number 153. Commonest cause of tricuspid regurgitation is cor pulmonale. We have already discussed this question. Answer is B, cor pulmonale. Again, it's of two types, acute and chronic cor pulmonale. Question number 154. Carvalho sign. It's a marker of tricuspid regurgitation. What is Carvalho sign? Carvalho sign is when the patient inspires, the blood flow in the right side of the heart increases, therefore the intensity of the murmur of TR increases. This is Carvalho sign. This is a sign elicited during deep inspiration. Question number 155. Answer is A. Giant A wave and slow Y descent is about in tricuspid stenosis. I will again make the diagram. A, C, X, V, Y. A, C, X, V, Y. Atrial systole, atrial diastole, ventricular systole. So, in tricuspid stenosis, when there is atrial systole, the tricuspid stenosis is there. So, patient will be having large A wave. So, this will increase, which is very obvious. You have tricuspid stenosis, the flow towards tricuspid valve is hampered, so the blood flows through the right atrium and the A wave is magnified. A wave is magnified. Similarly, Y descent, whenever there is ventricular systole which is finishing off at V point, there is a filling phase. There is a filling phase which cannot happen because already blood is there in the right ventricle. So, Y descent is again impaired. Question number 156. Graham-Steele murmur. Remember the name Graham-Steele murmur, it is a murmur of pulmonary regurgitation. So, answer is D. Answer is D, Graham-Steele murmur. It is a diastolic decrescendo murmur, best heard in left lateral sternal border. Question number 157. Answer is A. The reason why infective endocarditis is least likely to occur in atrial septal defect is, whenever there is a defect across two chambers, the most likelihood of development of endocarditis depends upon the regurgitation of the flow, or rather not regurgitation, this is the difference in the pressure. So, the difference in the flow which causes more of turbulence. So, left atrium, right atrium, the pressure gradient is not that much as it is compared between left atrium and left ventricle, or right atrium and right ventricle. So, that is the reason why atrial septal defect patients are least likely to develop infective endocarditis. Question number 158. Best investigation to diagnose endocarditis is 2D echo. So, no explanation required in this question. Question number 159. Spontaneous lobar hemorrhage in brain. This is lobar hemorrhage in brain, can occur in most likely in which condition? Well, Alzheimer's disease is one condition where you can have cerebral amyloid angiopathy, right? Although it is not associated with dementia, but it predisposes patients for development of cerebral hemorrhage. Next question is question number 160. Question number 160, the answer is D. The answer could be Guillain-Barré syndrome too. However, the important differentiating feature in GBS and Guillain-Barré syndrome is the duration of the disease, course and duration of the disease, that is 5 days, and a normal CSF examination. So, answer is D. Question 161. Most accurate test to diagnose SAH. See, this is a tricky question. There is a difference between most sensitive method or most sensitive method, and there is a difference most accurate test. Answer is D. Accuracy means you want to be 100% sure that patient has subarachnoid hemorrhage. So, you do a CSF, demonstrate blood in CSF, and that is the test which 100% confirms presence of blood, thereby indirectly presence of subarachnoid hemorrhage. CT scan is a good screening test for screening patient having subarachnoid hemorrhage. However, small subarachnoid hemorrhage, very early subarachnoid hemorrhage may be missed on a CT scan. So, it is a sensitive method, but not an accurate test to diagnose. Question number 162. This is regarding that the patient has loss of sensation on right side of face and all sensation on the left side of face. So, there is crossed problem with vertigo and meiosis in the right eye. Obviously, it is a posterior circulation problem. So, the answer is vertebral artery, and it is a lateral medullary syndrome. We have discussed it already. Answer is D. Question number 163. Most common cause of Charcot joints in upper limb. See, upper limb, obviously the lesion lies in the spine. So, syringomyelia is the answer. It is not diabetes mellitus, neurosyphilis or leprosy. Answer is C, syringomyelia. You have dissociated anesthesia, Kappe-like anesthesia in the upper limbs. Question number 164, rotating antibiotic therapy. The question itself gives you the answer. Question itself gives you the answer. Bronchiectasis is one condition in which you have recurrent infections. You have recurrent infections and you require antibiotics for longer periods and frequently. So, you try to give different type of antibiotics every time you have an infectious episode. So, it is answer is bronchiectasis. Question number 165. Wheezing in asthma occurs. See, wheezing is a phenomena, usually it occurs in expiration, However, as asthma progresses, that means if it is only occasional asthmatic episode, wheezing may be present in expiration, but for examination point of view, for students, from students perspective, wheezing is present both in inspiration, in expiration. Wheezing may be absent, in severe asthma. Remember it, absence of wheezing may be an ominous sign in patients having asthma. So, the answer is C. Again a tricky question, 166. Most common cancer in lung by asbestos. The immediate answer which clicks is mesothelioma, but again if you read the question is lung cancer, not pleural cancer. So, answer is D, bronchogenic carcinoma. 167. Fever is not a feature. See, bronchiectasis, you have lots of infection, you may have fever, miliary tuberculosis, you may have fever. In ILD, low grade fever is a possibility, but not necessarily there could be a fever. So, answer is B, ILD. Question number 168. Most common cause of SAH. The most common cause of subarachnoid hemorrhage is head trauma. That's written in books. Head trauma is the most common cause, followed by AV malformation, barianeurysm and hypertension. So, answer is D. Question number 169. Dandy's criteria is used for which condition? See, it is basically modified Dandy's criteria. It is for benign intracranial hypertension, benign ICH. The answer is C, benign intracranial hypertension. See, there is no pathological cause, there is no tumor in the brain, there is no evidence of papilloedema, right? Patients have a very high opening pressures of CSF, the patient is awake, there is no focal neurological deficit, there could be impairment of memory impairment and gait disturbances, memory impairment and gait disturbances. Question number 170. Which of the following are selective myosin activator? It is omecamtiv and mecarbil. Answer is B. No need to explain this again. Question number 171. Ephedrine is a class 1B antiarrhythmic drug. There is a very good mnemonic which is given in your explanatory book. Try to remember this. Ephedrine is not written, but remember it's a class 1B. Class 1B. Sorry. Answer is B. Question number 172. Pronator drift is seen in which condition? See, pronator drift is, what is pronator drift? You ask the patient to outstretch his hand, and after some time one of the hand which has spasticity will drift downwards. This is pronator drift. This is normal, this is pronator drift. So, motor neuron disease, yes, can have pronator drift. Even early stroke where there is spasticity, in stroke where there is a spasticity, you may have pronator drift too. So, answer is C. 173. Which of the following drug is a potassium channel activator? It is nicorandil. It is a selective potassium channel opener or activator, and it has a vasodilating property. It is a coronary vasodilator. Remember, it is a coronary vasodilator. So, answer is C. (174) Clevidipine, very similar to amlodipine. It is a calcium channel blocker. Self-explanatory question. Question number 175. Trifascicular block. See, what is trifascicular block? Trifascicular block is RBBB plus LAHB or LPHB plus first degree AV block. So, this is trifascicular block. So, out of these answer A, B, C, none of them is correct. So, answer is D. Question number 176. Most common valvular lesion in India and world, it is mitral valve prolapse. Question number 177. Most common feature in Ponson's disease. See, Ponson's disease is what? It's a form of reactive arthritis. It's a form of reactive arthritis in patients of tuberculosis. So you have a systemic lung tuberculosis. You start patient on ATT, he develops oligoarthritis. This is what is Ponson's disease. It responds beautifully to steroids. Question number 178. Question number 178. Bedaquiline. Bedaquiline is a new medicine developed for treatment of multi-drug resistant MDR TB. So remember this. It is available in India, but it is available only through regional MDR TB center. It is not available everywhere. 179. In BAL CD4 CD8 ratio is more than 3.5. So only one condition is sarcoidosis. Answer number is D. Question number 180. Question number 1. Most common symptom of primary lung carcinoma. It is cough followed by chest pain, followed by dyspnea, followed by hemoptysis. So cough is the predominant feature of primary lung carcinoma. So answer is A. (181). Pancoast tumor triad, it includes all except. Obviously there is no enlarged lymph node, so answer is D. Pancoast tumor is the apex of lung. It's not because of the lymph node. So the answer is D. Question number 182. This is regarding mesial temporal lobe epilepsy. It's one of the refractory epilepsy syndromes found. Drugs are technically not effective, so the only option is surgery. So answer is D. Question number 183. Brain tumor is associated with all except with, obviously the answer is Sturge-Weber syndrome. What is Sturge-Weber syndrome? Sturge-Weber syndrome is that you have some port wine strain, and these strain correspondingly they are there in the brain too, the blood vessels in the brain too. So over the scalp you have port wine stain, and in the same side in the brain you have the blood vessels which are dilated. So these patients present to you with seizures, port wine stain with seizures. Question number 184. Which of the following is last to appear in a case of acute rheumatic fever? It is chorea. May occur after weeks to even months, 6 weeks to few months, 2 to 3 months. In fact, chorea is one condition where you don't apply modified Jones criteria for a diagnosis of rheumatic fever. So answer is B. 185. Pseudo-resistant hypertension is seen in which situation? What is pseudo-resistance? Means that whenever the blood pressure is being measured, it is high during clinical settings. So the answer is C. But whenever the patient is at home or at rest, so blood pressure is normal. So this is pseudo-resistant hypertension. We should remember that 22 millimeter of systolic blood pressure and 11 millimeter of diastolic blood pressure, 22 by 11, if subtracted from the pseudo resistant hypertension, will be able to give you a fairly accurate picture of the BP readings of that person. Question number 186. Which of the following are used for treatment of congestive heart failure? It is coenzyme Q. Answer is C. 187. What's the first line treatment for acute pulmonary edema? It is not IV Lasix or IV diuretic or morphine. It is sublingual nitrates, which are venodilator, primarily venodilator, followed by IV diuretics. So answer is A. 188. Which of the following is the first feature of acute MI? The first feature of acute MI in ECG is tenting of T wave. Tenting. So P Q R S. This is tenting, and thereafter it becomes like this. So this is tenting of T wave. So the answer is A. Question number 189. Which is a benign condition? Wenck-Beck phenomena is a benign condition. It is type 2:1 AV block, type 1. It is a benign condition. Answer is A. By benign means that it usually doesn't progress into a difficult grade of block for which you may require a temporary or a permanent pacemaker implantation. Pulsatile lever and ascites is found in obviously tricuspid regurgitation. The answer is A, TR. Question number 191. Concealed conduction. What do you mean by concealed conduction? That some of the atrial beats are transmitted to the ventricle through the tract across AV node. So the answer is atrial fibrillation. Otherwise, the ventricular rate will not be so fast. So in atrial fibrillation, the rate is so fast that you have concealed conduction, right? So the answer is C, atrial fibrillation. Question number 192. True about DC shock treatment in AF. Remember, supraventricular rhythm are to be treated, if treated by DC cardioversion, with a synchronized low joule therapy. So synchronized 50 joule therapy is sufficient, 50, 100 and 150 is sufficient for atrial fibrillation, but it needs to be synchronized. All right. So the answer is A in 193 question. Destination therapy is given in which condition? It is congestive heart failure. See, there are two therapies, destination and bridging the gap therapy. Destination is like conducting a heart transplant. Bridging therapy is, see, attaching a external pump so that you give rest to the left ventricle till you have a successful transplant. So destination therapy is treatment, the final treatment therapy. Question number 194. NYHA class 3 with dyspnea, pedal edema and creatinine. See, the answer for this is spironolactone as well as enalapril as well as digoxin. However, so the question is slightly wrongly formulated. Which it should have been, which is the best drug which should be given if the following condition is there, that the patient has azotemia, the potassium is 4.5, but still he has some milder element of heart failure, because digoxin is technically not good whenever creatinine is more than 2.5. If you have potassium which is 4.5 with azotemia, even enalapril and spironolactone, they are not contraindicated, but they should be used with caution. So, answer is A, followed by C, followed by D. Question number 195, ascending weakness in lower limbs and upper limb. So, hyperkalemia as well as hypokalemic periodic paralysis can cause ascending paralysis in patients. So, we need to test this by doing a potassium. So, answer is B. Question number 196, which of the following feature of stroke need not to be treated? See, spasticity occurs after some time, and in books it is written that spasticity gives the patient confidence to move around. With flaccidity, he probably will be unable to balance his body in a proper way to conduct his day-to-day activities. With spasticity, it is probably a compensatory mechanism of our body's neurological system for optimization of functions. So, spasticity may not be treated. Neglect, dysphagia, fever should be treated. In fact, fever should be treated meticulously. It increases the chance of debility and death in stroke. The answer is A. Question number 197. It is regarding rabies. Regarding rabies, multitude tests are there. If you have corneal scraping, the best gold standard is getting a viral culture done. So, the answer is D. Question number 198. Drugs not used in CHF. See, nitroglycerin is used, spironolactone is used, nesiritide is used. So, the only drug which is not used is trimetazidine. Answer is D. Question number 199. See, a patient who previously had PCI 3 months back has acute coronary syndrome, probably non-ST elevation MI, because the ST segment is depressed and cardiac troponins are high. So, he has been loaded with the best medical management, and early vascularization with PCI is the best treatment of choice. Answer is B. Last question, question number 200. Sudden death can occur in patients of AS. It is very important. See, answer is AS. Why? There is a fixed stenotic lesion in AS. So, the movement demand, say for example, patient starts exercising and demand increases, the cardiac output does not match to the demand, patient goes into shock. So, even milder form of exercise with severe aortic stenosis may land up into sudden cardiac death. Thank you so much.